Good afternoon. I'm Peter Soukas from Brown University in Providence. I have the great pleasure of interviewing Dr. Larry Whitney from Lakeland, Florida, and Dr. Fritz Angle from Charlottesville, Virginia. We're going to be talking about a session that we just completed discussing the Gore Viabahn endoprosthesis as well as the Tigris stent and the VBX balloon expandable covered stent. So I think we're going to start off by talking about the Viabahn. So I'm going to actually pose my first question to Larry and ask Larry, in your practice, where do you really feel that the Viabahn adds value?
So in my practice, I tend to use Viabahns in longer lesions, longer SFA, even popliteal, heavily calcified lesions. You could probably speak to it better than I can, but I believe the data for heavily calcified lesions is extremely good. In the 84%, I want to say, at a year of primary patency. Viabahn really shines as far as long calcified lesions, long CTOs are kind of the wheelhouse for Viabahns. And then off-label uses, I tend to use them actually for fistulograms, so cephalic arch and also at flexion points, such as at the elbow. Mm-hmm.
And Fritz, how about in your practice, where do you feel the Viabahn fits into your
I would echo all that. I think those are just go-to for us. And then, we find it so useful in in-stent restenosis that doesn't respond to more expensive solutions. You just reline it, and you got a durable long-term solution. And I think really changes the biology of an in-stent stenosis completely. And then behind the knee, it's the most flexible stent. So if I have adequate size there and I got a long lesion, very valuable stent.
So maybe we can talk about which lesions we feel that Viabahn works really well for, and probably just as importantly, those lesions where we don't feel it works well. So perhaps Fritz, you could talk about vessel diameters and runoff vessels and where you feel that maybe it perhaps might not be your first choice.
Yeah, so definitely size of the vessel is a key determinant of when you can use the device. And the 5mm stent I find very safe in a vessel that measures 4 or even slightly less than 4. And I'd be curious to hear what your thoughts are, but somewhere around 4mm and up, if we've got that kind of lumen, it's great. If we have a very calcified lesion, I think that you can overexpand a very small vessel with a lot of recoil to a balloon nicely using Viabahn. So even though post-balloon you might only have a portion of it that measures 4, the rest of it, if it's calcified, you can overdilate it and get a good result.
Right. So let me ask Larry, in terms of number of runoff vessels, do you have a particular cutoff, or would you feel comfortable putting a Viabahn in with single vessel runoff, for example?
Yeah, I would say nothing is absolute, but I would say that if there is one, or certainly less than one, if there's nothing contiguous to the foot, then I would be a little bit more leery of placing a Viabahn. If it's a dominant single vessel runoff, and that's the patient's best option, then I may go ahead and do so. But ideally, I'd prefer a 2 or 3 vessel runoff. I think that would preserve patency. And I guess speaking to Fritz's point too about sizing, I would also add that, and as the data has shown, if you can oversize 20% or less, the data is much greater.
And we discussed in session, of course, how in both the Viper trial as well as in the Japanese IDE trial, if you didn't oversize the device by more than 20%, you had a remarkably high primary patency at 1 year of 88%, 79% at 2 years in the Japanese study. So I think it just speaks to the fact that you can get a very durable result, but you have to be really meticulous about sizing. And we talked about the use of IVUS in quantitative angiography. In our lab, we find that IVUS is much quicker and easier. We can just throw the IVUS catheter down there, get an exact size, which is of course what they did in the Japanese trial. And I think that probably is one of the primary contributing reasons, of course, why they had such a great result in terms of their primary patency. And then the other thing I think we probably should just mention is the antiplatelet regimen. In the Japanese trial, for example, they insisted on at least 6 months of dual antiplatelet. I will tell you, in our practice, we try to do at least a year, and if they have disease in other vascular beds, why not just leave them on it indefinitely?
Absolutely. I think that's the way most of us are practicing now. You know, we for years have just kept expanding and expanding the dual therapy, and finally come to realization, particularly now that it's much more affordable for these patients. Just leave them on.
Yeah, thank God. You know, Plavix is finally generic. You know, we actually did a study at our place looking at those patients who had Viabahn thrombosis, and it turns out that over 50% of them, when we went back and checked after the fact, were non-responders to Plavix. So in my own practice, I tend to check a platelet response test if I do put a Viabahn in, because if they're a Plavix non-responder, then I'll typically switch them to either Prasugrel or Brilinta in the hopes of avoiding a potential thrombotic event. So that's sort of one lesson learned over the years. I'm sorry, go ahead.
So I was going to ask you a question. You know, we don't look so much at the number of runoff vessels, but just the quality of the runoff. And I think all the theories that, you know, Viabahns go down hard and the quality of the runoff is important to that, I think have been debunked. Or is that a fair statement?
Absolutely. I mean, if you look at the Vibrant data in the Viper trial, they had only a single case of patients who had acute limb ischemia that needed to go to the OR because they just weren't able to be revascularized with thrombolytic therapy. So I think that's one common myth, that if it goes down hard. The fact of the matter is most patients will go back to whatever their baseline Rutherford classification was before they had the Viabahn implanted, and typically they're Rutherford class 3. So why don't we actually use that as a springboard maybe to talk about how you do, on those rare occasions when the Viabahn does go down, how do you typically treat them? So maybe, Larry, you could give us your algorithm.
Sure. So assuming it's acute, then we'll go ahead and we'll typically do catheter-directed thrombolytic therapy. We favor ECOS in our institution, but by all means, I think any kind of catheter-directed therapy via any infusion catheter is okay. And we, assuming they don't have any kind of bleeding diathesis or any kind of contraindications to lytics, we'll go ahead and run them overnight, typically. We've gotten away.
What do you typically run them at? Half a milligram, a milligram?
Yeah, it kind of depends on the circumstance. I would say, as a general rule, we'll do a milligram an hour, and sometimes I'll cut back to maybe 0.5 milligrams an hour overnight. But I'll typically start, maybe lace the clot initially with perhaps 4 milligrams just to get things kind of started. But having said that, if it's an older person, you know, 80, maybe a little bit higher risk for bleeding, for instance, I may go ahead and titrate that dose down a little bit right off the bat for fear of bleeding. We've gotten away from using angiojet. We're big penumbra users in our institution, so sometimes we'll use that for adjunctive.
I was actually going to ask Fritz, is there ever any occasion where you will use a mechanical thrombectomy device prior to lytic therapy or as an adjunct?
Yeah,
maybe to lytic
absolutely.
therapy?
You know, we all would love these always to be one stage, but we know safety first. If it's a long segment, you're not sure the clot burden, lyse them. But if I have a short stent, we also know that it's much like a native lesion. There's not a lot of clot in there, it's just unfilled stent. And so often if it's a relatively short stent, you know, distal protection, mechanical thrombectomy, whatever device you think is best, often you can one stage these, in my experience.
Yeah. I would echo those feelings. If someone comes in and if they have sensory dysfunction or they've maybe got a little bit of motor dysfunction, in that situation I'm going to try to get some flow down there to reverse that. And so throwing a filter down, doing either penumbra or angiojet, get some flow, and then once you have some flow and they're sort of back from the edge of the abyss, if you will, then you can just slip in your ECOS catheter or your fountain catheter and then just give them a few hours to sort of mop up any residual clot. The other thing that I found is that it doesn't take a lot of TPA to dissolve a Viabahn. You don't need a really prolonged infusion. I found that even 4 hours, 6 hours oftentimes is enough to really clean it up. And so if I'm doing the case in the morning, I'll typically bring them back in the afternoon, and more often than not, it's all cleaned up, and then I can just go ahead and deal with the underlying edge restenosis, which is typically what caused it to go down in the first place. So let me ask you, Larry, so what's your typical strategy for an edge restenosis?
So typically we'll go ahead and balloon it, maybe use a focal force balloon angioplasty, perhaps use drug-coated balloon. If I feel like I'm getting a lot of recoil or there's some residual flow limited dissection or whatever it might be, then I may go ahead and add a adjunctive stent
Is that your?
It's very similar. I
Policy
think we need to look more at the benefits of using drug-coated balloon at the edge. But every stent is prone to sort of a candy wrapper effect, I think the tapered end of the Viabond makes it about as good or better than any. But DCB on the distal end, either primary event or recurrence, is a great idea.
Right. And a lot of patients are typically treated with drug-coated balloon, but as we've seen from the literature, we talked about that in our session earlier, that unfortunately there is this late catch-up phenomenon with DCB. The primary patency rates, particularly in lesion lengths that are more than 20 centimeters, are really only about 60% at 1 year, and we know there's a pretty precipitous drop-off at the end of 2 years. So for patients who can be treated with a covered stent, it really does offer that durability. And I'd be curious, Larry, you're a vascular surgeon, as to your thoughts about the Super B trial, which of course was presented at Link now, where the 2-year follow-up data, which was a randomized trial of Viabond versus bypass, the gold standard, 2/3 of whom had vein bypass, and showing no difference at all in terms of clinical outcomes or freedom from TLR. And so I'm wondering, how does that factor into your particular practice pattern, particularly as a vascular surgeon?
Actually, I'm an interventional radiologist, so it won't impact my decision making as far as the surgical side necessarily, but we work hand in hand with our vascular surgeons. And so, again, I think as long as you're not doing any harm to any patients, by all means, it's a less invasive strategy. We'll go endovascular anytime that we can first. And a lot of times it's hard to get our vascular surgeons to operate, quite honestly. A lot of times these patients have had multiple interventions, they have a lot of comorbidities, they're not always the best operative candidates. They might have a lousy runoff or whatever, so whatever it is, they might not have a good distal target for their own bypass. So if we can fix it with a Viabond, then by all means we'll do so.
Sure, okay. In terms of in-stent restenosis, we know, Fritz, that's a particularly vexing problem that we all have to deal with. So for these long, say for example, Soukas 3 occlusive in-stent restenosis, where do you see Viabond fitting into your treatment algorithm?
Well, it depends a little bit on the stent you're working with underneath. But if you have a nitinol stent, you got a little ability to debulk it, you can make an adequate lumen for the Viabond, it's a great solution. So if you have those stents that have recurred twice, or you're not pleased with your debulking, whatever device you prefer to use, I'm going to reline those. You've got to make sure you've got a good anatomic result before you quit. That's the most important thing. And if you're not getting that with atherectomy, then probably you should think about relining it.
Yeah. I mean, we've seen some very limited data. Gandini's randomized trial in a 2-center study that was recently published earlier this year, where they used laser and drug-coated balloon, and primary patency rates in one study were 60% at 1 year, 70 in the other. So although that is something that people are looking at, combination therapy, it still doesn't equal the primary patency of just relining it. And the other thing that we should talk about in terms of both long lesions and treatment of in-stent restenosis with drug-coated balloon is the fact that you're typically treating anywhere from 30 to 40 centimeters of vessel. And that's typically going to require 4, maybe even 5 drug-coated balloons. One of the knocks against covered stents, of course, is that they're not cheap. But when you factor in 4 or 5 drug-coated balloons, it actually ends up being more expensive to use a drug-coated balloon strategy, particularly if you're going to then throw in another $2,500 atherectomy device ahead of time. So, ironically enough, the covered stent may actually be a more cost-effective treatment for a really long in-stent restenosis. Do you think that argument holds merit?
I think your logic makes sense for long lesions. I would be, I would use a more conservative approach for 15 centimeters or less. But if you're up in the 25, 30 range, I totally agree with the logic. I think that if you look at the safety of trying to debulk all that, even with distal protection, you're going to have more complications as well. So sometimes it's just safer just to get this done and just reline it.
Right, because the covered stent will exclude any potential thrombus or plaque. All right, so we talked about Viabond for treatment of long lesion lengths and for in-stent restenosis. So why don't we maybe switch gears for a second and talk about Tigris? Tigris is a very flexible, conformable stent. It's a fluoropolymer, single nitinol, so it's very flexible. There have been no reported stent fractures with the device. So, Larry, let me ask you, where do you think Tigris might fit in terms of specific anatomic locations? For example, in the distal SFA in the pop, you think there's a role there?
Yeah, I think you hit the nail on the head with the flexibility, the conformability, the fact that it can handle the longitudinal and axial loads, the torque, all the different forces that happen in the SFA and even popliteal artery. That's, again, I think the adductor canal and at the level of the knee, I think it's a great indication. I think it handles calcium well, like you mentioned, no fractures, even out to 3 years in their ID trial, the ID study that came out. So really quite amazing. The French multi-center trial had an 82% primary patency rate. I think the data is really phenomenal for the Tigris. So.
Actually, there was a recent report, Dr. Werner and his group in Austria looked at their data using Tigris in 100 patients. And they had a 93% primary patency and freedom from TLR at 1 year, which is pretty remarkable considering that they were all placed in the distal SFA and the above knee popliteal artery, which is typically a pretty hostile environment. Obviously, we know there's a tremendous amount of bending that goes in there. And so the other issue, I guess, that you had mentioned earlier in the session was the ability to place it very precisely. Mm-hmm. So maybe you could speak to that for a moment.
Yeah, so actually when they did the trials, they found out that all of the implanted devices all deployed accurately, precisely. There was no longitudinal. They were all within the appropriate length, essentially. So I guess to summarize what I would consider placing them, when I would consider placing them, anytime I would think of placing a Supera, essentially an IDEV stent, that's when I would place a Tigris at this point. Mm-hmm. I think it has a lot of the same features, but I think as far as the accuracy of deployment is really where it shines.
Right. So. Fritz, where do you see that particular device in your armamentarium?
Yeah, I think I would echo your thoughts. You know, it's a shoe-in for behind the knee, and I think the one point I can add is that you know, no stent is perfect. It's just a hostile environment for any stent. But if you have to do a re-intervention, if you're looking for an assisted patency, I find that stent is pretty easy to work with. You can come back and overdilate it, unlike mm-hmm. another stent that's commonly used behind the knee, and that sometimes makes the difference between getting a technical result and not. And I think that you know, in smaller vessels where you can't use a fully covered stent, you can't use a Viabond, it's useful.
Sure.
If I could make a comment too about the radial strength, it's the same radial force as a Viabond. And when they looked at the study, the Tigris study that came out, 99.5% of the implanted devices had less than 30% residual stenosis after the original deployment. So quite phenomenal,
right.
The outward force exerted by it.
Sure. And then, of course, it does have the heparin coating, so potentially may have some thromboresistance as well.
Correct.
So why don't we maybe sort of finish up and talk about the VBX. Mm-hmm. The VBX device, of course, is now commercially available, and maybe, Larry, you could talk about the size and the ability of the device to be expanded to different diameters.
Sure. So first of all, VBX has the most number of stent sizes available on the market of any product as far as covered balloon expandable stents are concerned. And so the beauty of it is you can place them through 7 or 8 French sheaths, which is nice. So you can stay lower profile. At the same token, you could take the larger ones, the 9, the 10, the 11, up to 13, and you can even take the largest one up to a 16 millimeter device, which is comes in awfully handy for treating certain
for aortoiliac bifurcation.
Exactly. And you know, no iliac is the same, even from when it starts to when it finishes. There's a lot of variation in iliac diameter, or even in the same patient. You can go from an 8 to a 16, or a 10 to a 6. There's a lot of variability, and so having that ability to kind of flare out or taper the stent, I think, comes in really handy in the iliac setting.
Right. Fritz, maybe you could talk about your experience with the device in terms of its deliverability and conformability, and where you feel it particularly adds value to your practice.
Yeah, so it's a flexible device. right? So if you're doing an iliac up and over, it's going to track. You're not going to get wedged at the aortic bifurcation. I think, one of my, pet projects is always to worry about reconstructing the aortic bifurcation. The conformability is key there. We would love to have all the conformability of a self-expanding stent with the rigidity of a balloon expandable stent. And I think the VBX is about as close as we've got for that right now. So if you're trying to reconstruct an aortic bifurcation, you also need to oversize those stents a lot more than you'd think to get rid of the dead spaces. And that's a stent that allows you to go back and post-dilate it. You go in, you do IVUS, you do angiography. I don't have good wall apposition yet. No problem. Go back, maybe with a compliant balloon, dial it up, try and get yourself a little bit better contact with the wall, hopefully prevent some late restenosis or thrombosis.
Right. So, Larry was talking about the VBX data out to 2 years. And Larry, maybe you could talk about the patency rates and the freedom from target lesion revascularization rates out to 2 years.
Yeah, so the freedom from TLR in all comers was greater than 93%. And if you look at the task 2 C and D patients, it was actually close to 96%. And if you look at the freedom from clinically driven TLR, it was in the upwards of 98%. So quite phenomenal data, and that's at 2 years. So very, very durable results. Excellent results within the first 9 months and 12 months of the study, and then now that we have the 2-year data, we're seeing that it's actually extending out for an additional 12
Maybe
months.
we could talk about VBX outside of the aortoiliac space. Yeah. I found it particularly effective and very helpful for more tortuous subclavian lesions, particularly if they're quite calcified or if it's a subclavian occlusion where I'm obviously always terrified about the possibility that could be subintimal and the risk of a perforation, which of course in that space would be disastrous. So maybe you could each chime in about where you've used it outside of the aortoiliacs, for example, mesenterics, renals, subclavians, and if you found any value of it in those particular beds. Yeah,
so I'd say the 2 places outside of the iliacs, SMAs, for the reasons you mentioned, traction on corners, relatively low profile, very precise placement. Those are 3 of the things that are really important to us. And then we like to flare the origin of those. So you put one in appropriately sized for the distal SMA, and then you can size it, dial it up, whatever you need to get a good apposition at the SMA origin, because so often the SMA origin is so flared. You need to really dilate that thing up sometimes 3-4 millimeters more than you do the distal end. So it's a good application. I'd say the other place is in endograft work. And for fenestrated grafts, for the same reasons. You put in one appropriately sized for the renal artery, and then you flare the osteo out very nicely, get a good apposition to the fenestration. So very useful, I think, in endograft applications.
And Larry, I'm assuming you've had some similar experiences as well?
Similar. I agree with your assessment of the subclavian artery. I think it's a great spot for it. We actually had a competitor that we put in, and it actually occluded the next day, and we got a CT and actually showed that it had kinked and actually had closed off the ostium of the subclavian artery. So that particular stent, whereas I think the VBX, again with that rigidity, but at the same time having that flexibility by having the independently linked, steel reinforced lattice network, really helps to keep it open.
Right.
But in getting to your question, I like to use it in, to Fritz's point, AAA cases. I think snorkels in our institution we do quite commonly, and so we employ it frequently in snorkel cases, IBE cases. We'll also use it, like you said, for visceral work as well. SMA, perfect. Certainly we know that covered stenting has better patency rates than bare metal stenting in the SMA. So as long as you're not covering any branches, I think by all means, VBX has a great role.
It may be early, but have you had any experience using it for in-stent restenosis?
In places other than the iliacs, you mean?
Anywhere.
Or yes, in the iliacs, yes. Relining iliac on previously placed bare metal stents. And same thing with in the viscera as well. SMAs, celiac. I think those are probably the biggest ones. Certainly, we see a lot of uncovered stents being placed in the central venous circulation as well. We do a lot of fistula work, a lot of dialysis work. And so a lot of times patients will be coming in from outside places, a lot of OBLs and things that are placing a lot of uncovered stents, which certainly have inferior patency rates compared to covered stenting. So I think it's a great place to reline.
Sure.
And you can stay low profile. You can go through 8 French and make it up to 16 millimeters.
Right.
Off-label.
Of course. All right. Any additional thoughts about VBX,
Yeah,
Fritz?
one thing I would add is I'm going to talk this afternoon about iliac aneurysms, and that was came up again and again as I looked through the literature on treatment of isolated iliac aneurysms. It's got the features you need. You need to make a seal zone and a 12 millimeter common iliac. You can dial it up to that. And if you're going to do a branch graft or some branch device for an iliac, it also is a great way to extend into the internal iliac or the external iliac arteries. So it provides a lot of brings extra tools to the table when you're treating iliac aneurysms.
Terrific.
Yeah.
All right, I think we've had a really terrific discussion here on both Viabahn, the VBX, and the Tigris. I'd like to thank Fritz and Larry for joining me today, and we look forward to everyone having a wonderful meeting here at C3 and the Interventional Academy. Thank you.
All right.